Hello everyone, welcome to my new video. This is on degenerations of conjunctiva. Here I'll be covering two topics, Pinguecula and Pterygium. Both of these conditions are extremely common, seen on daily basis in the OPDs. The patient may come with complaints of a mass uh, in the interpalpebral area, or he or she may come due to a different cause, loss of vision due to any other cause, and incidentally, we may notice pinguecula or pterygium. So, pinguecula is basically asymptomatic elastotic degeneration of the conjunctival stroma. A yellow-white mound or aggregation of smaller mounds may be seen on the bulbar conjunctiva just adjacent to the limbus. It can be nasal, more frequently it is nasal. It can be temporal, or it can be present both at the nasal or temporal bulbar conjunctiva. We may even see calcifications there, and the etiology of pinguecula is believed to be due to actinic damage. Now, a point to be noted here is that both pterygium and pinguecula both have similar etiology and histology. In pterygium also, I'll tell you that the cause is believed to be actinic damage, and thus there's an increase of fibroblast seen on histology due to actinic damage. So the differentiating point between pterygium and pinguecula is that the limbal barrier to extension has remained intact with pinguecula. That is, the pinguecula will never extend beyond the limbus. Now, sometimes the pinguecula may become acutely inflamed. Uh, this we'll call as pingueculitis. And if the lesion is prominent or there's calcification, it may lead to epithelial breakdown. There's a small subgroup of patients where the inflamed nasal pinguecula and impaired ocular surface lubrication, and these patients may progress to pterygium. So that means that the limbal barrier to the extension will not remain intact, it will break down and they will progress to pterygium. So since pingueculitis is not crossing the limbal barrier, it will not cause a problem in vision. So the treatment is usually unnecessary. Patient may demand treatment due to cosmetic reasons, or if there's a case of irritation, then we can give topical lubrication. For inflammation, pingueculitis, we can give topical steroids, mild or short course topical steroids. Excision may be done, as I told you, for cosmetic reasons, or if it is causing significant irritation, then we may go for excision. That depends on the demands of the patient. And simple excision is usually adequate, since the recurrence rate is very low for pinguecula. Thermal laser ablation can also be done. In light-skinned individuals, there may be need of gentian violet marking, so that adequate absorption occurs of the thermal laser. Coming to images of pinguecula. So this is a pinguecula. As I told you, it is a white yellow mound seen on the bulbar conjunctiva, just adjacent to the limbus. This is a developing calcification, and here you are seeing this much of redness, so this is pingueculitis. And this small extension here crossing the limbal area, so we can say that this pinguecula is progressing to a pterygium. Coming to pterygium. Pterygium is a triangular fibrovascular subepithelial ingrowth of degenerative bulbar conjunctival tissue. So here an important point to be noted is subepithelial ingrowth. That means epithelium, the thickness of epithelium is normal in pterygium, and this is important to distinguish it from OSSN. I'll tell you this in detail later. Risk factors for pterygium is sunlight, UV rays, which causes limbal stem cell damage and increase in matrix metalloproteinases, dryness, dust, and it runs in families, so it has a genetic predisposition to it. Due to sunlight, dryness, and dust, it is more common in males who work outdoors, as in farmers, and they are exposed to sunlight and dryness. Ocular surface markers are defensin, phospholipase T3, and there's a regulation of growth factors. Coming to the histology, it is elastotic degenerative changes in vascularized subepithelial stromal collagen. The word elastotic means that they don't degrade with elastase. Uh, a detailed histology will show that the epithelium, the Bowman's layer, and the superficial stroma are often destroyed, and the damage is actinic induced. So, as I told you in Pinguecula, here also there's increased fibroblast. So, we can say that the damage is actinic induced. The differential point is that, in contrast to Pinguecula, the pterygia enroaches onto the cornea and it invades the Bowman's layer. Pterygium is a more of a proliferative disease than a degenerative condition. It is a fibrovascular subepithelial ingrowth, so it is more of a proliferative disease. There's proliferation of fibrovascular tissue, inflammatory infiltration, fibrosis, angiogenesis, and there's extracellular matrix breakdown also. An important DD of pterygium is pseudopterygium. Uh, that is a band of conjunctiva that adheres to an area of compromised cornea at its apex. So, a pseudopterygium often occurs due to a chemical burn, a marginal corneal ulcer, a trauma, or a cicatrizing conjunctivitis. So, thus it becomes important that when you see a mass that is resembling a pterygium, we should ask the patient about any form of trauma, any form of chemical burn, which may lead to the development of pseudopterygium. Now, coming on to types of pterygia. So, the pterygia can be progressive or regressive. Progressive pterygia has basically thick, fleshy, vascular pterygium, and there are few whitish infiltrates in the cornea. So, these whitish infiltrates are commonly known as cap. These are also known as Fuchs spots or islets of Vogt. A regressive pterygium, on the other hand, it is thin, atrophic, and attenuated with decreased vascularity, minimal vascularity, we should say. There's no cap, but there's a iron line, iron deposition, and it is known as Stocker's line. It becomes membranous, but it never disappears. Coming on to clinical features of pterygium. So, the basic point is that if there's a recent enlargement, we should go for early excision. And if the pterygium shows extremely aggressive growth or it is of atypical appearance, then we should go for prompt excision biopsy to rule out any kind of neoplasia like OSSN. I'll tell you in detail what are the points for a atypical appearance of pterygium. So mostly the lesions are very small and they are asymptomatic. The problems what a pterygium can cause is irritation and grittiness that can occur due to a delin. So what is a delin? Basically, the advancing edge of the pterygium can interfere with the precorneal tear film, and that will cause a drying effect. So we call this a delin, and it will cause irritation and grittiness. The other point is that the patient who wear contact lenses, uh, in case of pterygium, the edge of the contact lens will lift, and that will cause irritation. The main problem with pterygium is, especially aggressive pterygium, it can cause obstruction of vision due to encroaching upon the visual axis. If the pterygium comes onto the pupillary area, so it will obstruct the visual axis and there will be loss of vision. Also, it can induce astigmatism due to changes in the corneal topography. Like pingueculitis, it can also show intermittent inflammation, and obviously cosmesis. Cosmesis may cause a significant problem because there's a white mass which will be seen in the interpalpebral fissure. So cosmetic problems may concern the patient. Rarely, pterygium can cause some complications like cystic degenerations, infections, or changes to neoplasia like epithelioma, fibrosarcoma, and malignant melanoma. Here are some images regarding pterygium. This is the histology of pterygium, which is showing collagenous degenerative changes and vascularized subepithelial tissue. This is the Stocker's line, which I was talking about in the regressive pterygium. This is a line of iron deposition at the cap of pterygium, and this is known as Stocker's line. Then this is showing redness in the area of pterygium, increased vascularity. So this is a inflamed pterygium, and this is a typical pseudo pterygium which has occurred due to chemical mold. Now, another problem what pterygium can cause is that if a extensive or a recurrent lesion is present, then it can cause subconjunctival fibrosis. It can extend to the fornices, and then it will cause restricted ocular movements. Coming on to the signs of pterygium. So the pterygium is made up of three parts. There's a cap, there's a head, and there's a body. The cap is a avascular halo-like zone at the advancing edge, on which I showed the Stocker's line. Then there's a head on the cornea. We can say there's a constricted part present on the limbal area, and we can call it the neck. Then there's the scleral part between the limbus and the canthus, and that is called the body. Mainly it has three parts: cap, head, and body. Then there is Fuchs islets, or the small discrete whitish flakes, which consists of clusters of pterygial epithelial cells, and they are present at the advancing edge or the cap. A distinguishing point from pterygium and pseudopterygium is that the pseudopterygium is located away from the horizon, and there is a firm attachment to the cornea only at the apex, or only the head is attached. So the pterygium is the cap, head, and body, all of that is attached to the cornea, but in a pseudopterygium only the apex or the head is attached. Coming on to the treatment of pterygium, like Pinguecula, here also we will, among the medical treatment, we can give lubrication, mild steroids, and as a prophylaxis, we can ask the patient to wear sunglasses and reduce UV exposure. Surgery is the definitive treatment for pterygium. So the problem with pterygium is that it has a high recurrence rate, and if we do simple excision, that is we leave the sclera bare, that will cause a very high recurrence, like around 80% recurrence it will cause, and often it will show a more aggressive behavior than the original lesion. So the bare sclera technique is not preferred. What we do is there are methods of preventing recurrence. First is CLAU, that is conjunctival limbal autograft. We will do the surgical excision, and then with a free conjunctival limbal autograft, and it is the most preferred technique nowadays. The second method is to prevent recurrence, that is surgical excision with amniotic membrane graft and using mitomycin C of 0.02% concentration. This method is preferred if there's recurrence or the lesion is very large. The third method is that we'll do surgical excision with lamellar keratectomy and lamellar keratoplasty. This is preferred if the lesion is deeply infiltrating, it is recurrent, or there is recalcitrant pterygium. Coming on to the surgical technique of pterygium excision. So after topical anesthesia, eye is cleansed, draped, and exposed using a universal eye speculum. Then the head of the pterygium is lifted and it is dissected off the cornea. Then the main mass of pterygium, it is separated from the sclera and the conjunctiva superficially. Now the pterygium tissue is excised, and we have to take care that the medial rectus muscle is not damaged. After this, hemostasis is achieved and episcleral tissue is exposed, and it is cauterized thoroughly. Now, conjunctival limbal autograft transplantation is used to cover the defect after the excision. And as I told you, this is the latest and the most preferred technique nowadays. We can use a fibrin glue to stick the autograft in place. It is a fast procedure. It reduces the operating time, and there's no discomfort associated with the sutures. Coming on to the last slide, as I told you that there are some atypical features of pterygium which we have to keep in mind in order to rule out OSSN. So if there are calcifications, leukoplakia, atypical elevations, or irregular feeder vessels, a very important point, or there's extremely aggressive rapid growth, then these features we should think about OSSM. And in order to differentiate, we should go for a ASOCT. In ASOCT, these images, we can see that this is a pterygium, and there is a normal thickness of the epithelium above the subepithelial ingrowth here. And here this is OSSM. So this is the normal thickness of epithelium, and this area shows a grossly thickened epithelium. So we can differentiate between the two. Thank you.